Treatment planning is important for the success of any dental treatment, including implants. Following this chapter, students should be able to identify some factors to consider during treatment planning, including the use of diagnostic tools and the following treatment phases. During the examination and diagnosis, it is important that we know what the patient wants, expects, and if there are any barriers, be it medical, physical, or psychological. The information that we get from the history will help us customize the management for our patients to suit their needs. History taking must include the dental, medical, and social history, and sometimes even the diet history should be obtained. A diet history is especially useful when the patient has a high caries experience or suffers from tooth surface loss. The pattern and type of dietary consumption may be the etiological factor in these conditions. Any extraoral abnormality or discrepancy should be detected during the treatment planning stage. Next is the intraoral conditions. Presence of disease must be identified, and if need be, referrals must be included in the treatment plan. Special investigations serve as diagnostic tools to aid treatment planning. With implant treatment being a prosthetically driven treatment, it is important that we visualize the final restoration and plan backwards. Some of the diagnostic tools include radiographs and cone beam computed tomography, mounted study casts, and diagnostic wax-up. We take radiographs to help us with diagnosis, to monitor the disease progress, and also for assessment of the outcome of treatment. When taking radiographs, it is important that we stick to the ALADA principle, or as low as diagnostically acceptable. This means choosing the type of radiograph that will yield the most information and at the same time keeping the dose of radiation to as low as possible for the patient. An example of this is, if you want to diagnose caries, you would take a bite wing and not a CBCT. We may take a CBCT for implant planning to assess bone volume and to know the locations of vital anatomic structures to avoid them during surgery. In non-critical regions, panoramic imaging or a periapical may be sufficient. We basically want to transfer what we see on the patient's face to the articulator, so our next diagnostic tool is study casts mounted on semi-adjustable articulator. The mounted study casts allow us to assess all teeth, the occlusion, and plan any tooth or occlusion adjustment without any hindrance of soft tissue or tongue that are present in the mouth. Apart from this, mounted study casts can also be used as communication aid during discussion with the patient. For cases of complete denture and removable partial denture without stable occlusion, we record the jaw registration using centric relation. Both the pictures above are the same set of casts, but the first is mounted in intercuspal position and the other is in centric relation. In centric relation, we can see that there is space to restore the anterior teeth. A diagnostic wax-up is important for implant treatment as we would like to visualize the final shape and location of tooth for us to plan the surgical and restorative phase of implant treatment. A radiographic stent and a surgical stent can then be prepared from the diagnostic wax-up that will aid in this planning. Following examination and all the special investigations, we can then diagnose the patient. Most times, the patient will have more than one diagnosis depending on his dental condition. Next, let us move on to the treatment planning. The treatment planning sequence must address the 5 categories, including emergency phase, followed by stabilization of primary disease, be it caries, endodontics, or periodontal problems. Following this, the patient is re-evaluated and the appropriate processes can be made. No treatment is complete without a recall. Most times, patients will have to be reviewed after 1 week to assess their acceptance and arising problems following an implant treatment. Following this, a customized maintenance plan is made for the patient depending on the type of treatment received. Now, we shall summarize all those mentioned regarding treatment planning by going through an example of the patient's case. This patient requested for implant treatment to replace his lower right posterior teeth. Apart from history taking, these intraoral photos serve as a useful aid during treatment planning and also serves as a patient's record. His panoramic imaging shows severe bone loss due to chronic periodontal disease. This patient's diagnoses are generalized chronic periodontitis on reduced periodontium in moderate stage and acquired missing teeth. His initial treatment plan includes oral hygiene instruction, full mouth disinfection including scaling and prophylaxis, root planing of 1,6, 1,7, and 2,6, and tongue cleaning with 1% chlorhexidine, and the application of a desensitizer. The final treatment plan comprises of bone augmentation and implants placement at 4,6 and 4,7, coronally advanced flap-fold gingival coverage of quadrant 1 and quadrant 2, with connective tissue grafts at upper right 3, upper right 5, upper right 6, upper left 3, and upper left 5, and fixation-plasty at 2,6 and 3,6, supportive periodontal therapy, and 2 to 3 months follow-ups catering to the patient's needs and compliance. This slide shows the diagnostic wax-up and the digital planning done for the fabrication of a guided surgical stent using data from the CBCT. 2 implants were placed to replace the missing 4,6 and 4,7 using the surgical stent. It can be seen that the implants placed were parallel to each other. However, as anticipated during planning, some threads of the implants were exposed and will require grafting. The photos show the grafting procedure and the post-surgical periapical radiographs taken showing the 2 implants placed. It is anticipated based on the literature that the survival of the implants placed in the patient is good, provided that the disease is controlled and the patient undergoes regular maintenance. The patient was also informed regarding the risk of greater implant loss for patients treated with chronic periodontitis as opposed to healthy patients. We hope that you have enjoyed this treatment planning module. Thank you for your participation.